Welcome to HiNZ 2017, and I'm talking to Levi Thatcher. Levi's subject is on artificial intelligence in healthcare. Welcome,
Thanks for
Levi.
having me.
Yeah. Levi, I sat in on your session this morning, and it was really, really very good. The first thing you said was, which pleased a whole lot of us, was you said you set aside all of the definitions and said we'll treat machine learning and AI as one and the same. I think that was helpful to some of us.
Trying to be practical.
Trying to be practical. But one of the first things you showed was an aspirational statement, which I thought was really great. There was a lot of words in it. I didn't take it all in, so I'll look forward to seeing the slide. But can you just give us some of the key messages that came out of that statement that you gave?
Yeah, the biggest idea is to be able to use data on past patients and their outcomes to deliver optimized care for the individual that's in front of the clinician today. So, no clinician can remember every past, patient they've interacted with and what exactly their treatments were and their outcomes. And so the idea is to use algorithms to search across and find those patterns such that the clinician can be offered up, optimized choices, A, B, and C with a corresponding likelihood of success and a corresponding cost. Cost is a big deal in the US and I imagine worldwide as well. So that's part of the aspirational statement, is learning from the data to be able to offer up those recommendations.
Mm-hmm. And is this something that a physician will talk to his patient about as to how he's using that information?
Yeah, especially in non-acute situations. So if you're having a diabetic checkup with your clinician, you would imagine the clinician even showing you how they can interact with the model and saying, with your current state, here's what your risk of mortality is over the next 5 years. And if you made these small adjustments to your lifestyle, if you exercised a little bit more or handled your A1C a little bit better, here's how your likelihood of mortality would drop over that time period. So definitely getting the patient involved for sure.
Getting to understand how this information
very
was being used.
Empowerment story.
You also talked about the elements to be used in machine learning in terms of healthcare. Could you go into those a bit more?
Yeah, the elements, sort of the drivers behind the risk scores.
Yes.
Yeah, so what we're excited about is making it such that with whatever data you have, you can create a model and drive this sort of risk prediction. So if you have variables around heart failure, use those to create a model. If you have variables around infection, you can use those. So it just depends on the use case. If you're predicting an infection, it'll be a different set of variables than if you're predicting readmissions or mortality or amputation risk for diabetics. But the nice thing is you can work with whatever data you have that's available.
Mm-hmm. And I think you mentioned also that one of the key things was gaining the trust of, or involving clinicians.
Yeah, definitely.
Could you talk a little bit more about that? How do you actually go about involving them
great
in
question.
the process?
Yeah, so two pieces. So first off, when you're developing the model and you're trying to get at these variables that you mentioned, you want to use the clinician's help to find where they are and which ones might be relevant. So you're incorporating them in model development. And then once you have a model in place that's driving this risk scoring every day, you also need to have some context in those predictions such that clinicians can see for Joe, Sally, or Jim why it was that they had high risk scores. So was it that they were a smoker or was their weight too high? So you want to use context on that end and then bring the clinician for model development on the front end so that they feel like they've had a part in the process and know the tool and can trust it.
Do you typically, we've learned sort of in the field of telehealth that we often rely on champions.
Exactly,
the pre-converted. So is that typically, if you're involving in the development of a model, you're looking for?
You want a champion, exactly. Yeah, we don't want to just put models out there for the fun of it. You need somebody that knows the health system, knows the goals, knows the business, and can understand what will most impact patient care. And if you have somebody like that championing the project, it's much more likely to succeed.
Mm-hmm. And then how does it work in terms of maintaining the currency of the models? Is there an iterative process?
Yeah, definitely iterative up front. So you may check out 30 different variables and see their impact on the likelihood of a person's risk of something, and maybe you only need 15 of those, but you maintain measurements over time, so you're checking in constantly with the model and checking its accuracy. So if it drops for whatever reason, you can go and retrain it and get it back on track. But definitely you set up what's called telemetry there to keep in touch with it daily.
Mm-hmm. And in your experience, Levi, are there any particular clinical areas or specialties where the models seem to develop better, quicker, work better than others?
Yeah. So central line infection is a big problem in the U.S. and worldwide, and that is a model where it can get pretty accurate pretty easily. So there's a limited set of factors that drive what we call CLABSI risk or central line infection risk, and those have been our most accurate models. And the nice thing about it is that it's dependent upon what folks are doing in the hospital. It's not so much dependent on socio-determinants of health. So clinicians can do things to actually reduce that risk pretty easily.
Mm-hmm. And any other specialties that sort of come to mind?
Well, our heart failure readmissions model is beating everything in the literature, so we want to get that out there more and explain, what variables it is that drives that. And readmissions is tough. A lot of health systems struggle with it, and if you focus on a particular cohort, like the heart failure patients, you can get a pretty good sense as to who's coming back or not. So that's been another one where we've seen success.
Mm-hmm. And have those models been effective in reducing the readmission rate? Have you been able to correlate the two?
Yeah. It's still early days for that model. We just barely got it in production, so the outcome success story is to come. But for CLABSI, we have seen models in production that have been driving 20-30% reductions year over year in infection rates. Mm-hmm. So that one's a little more tried out in the real world.
Real world. Any others that are on stream that you're developing?
So I don't know if this is much of an issue worldwide, but propensity to pay in the U.S. is a big problem. So more of the burden on payment is being pushed to the individual, and so we have propensity to pay models that help not only the individual but the health system both to see who needs charity care or who needs a balance reduction in terms of their bill. The patient's life's improved because they can actually pay maybe a $2,000 bill instead of a $5,000 bill, and the healthcare system actually gets some money instead of no money. So it's sort of a win-win for both the patient and the health system. Mm-hmm. So this applies across financial, operational, and clinical use cases.
And clinical uses.
Yeah.
I think you also talked about, towards the end of your talk, about accelerating, how machine learning is accelerating the outcomes. Could you just go into that a little bit more?
Yeah, so it's difficult to there's the term we use, boardroom analytics. So when health systems first get data, they set up dashboards and they look back. And it's hard to look back and take those lessons and apply them to the patient that's sitting in front of you. So the acceleration comes in clinical decision support and actually putting risk scores and context for those risk scores in the clinician's workflow. In the U.S., it's often in the EHR, but wherever the clinician's going to interact with the patient's data, that's where you need to put the risk score and the guidance. Because if you're just looking retrospectively at what happened last quarter or last year, it's tough to take that and translate it into your patient care for the patient in front of you. You really need the scoring and the context just serviced up right in the room with the patient. And even allowing the clinician to interact with the model with the patient there, having sort of a two-way conversation about it is best.
Mm-hmm. That's great, Levi. Thank you very, very much.
Thank you.
Thank you.
Appreciate you having me.